For weeks, night nurse Margaret Chen had been documenting strange incidents on the geriatric ward. Patients' personal belongings going missing, elderly residents found in rooms that weren't theirs, and most disturbing of all, several patients repeatedly mentioning a man who visited them at night demanding payment for protection. When Margaret tried to investigate, she discovered that someone had been systematically erasing her incident reports from the system. Her decision to conduct her own surveillance would uncover a crime that shocked even veteran law enforcement officers. Before we dive into this incredible story, let us know where you're watching from today. And if you like this video, don't forget to subscribe. Margaret Chen had always been drawn to the night shift at Riverside General Hospital. After 18 years as a registered nurse, she found the overnight hours on the geriatric ward to be when she could provide the most meaningful care to her patients. The pace was slower, the atmosphere more peaceful, and she had time to truly connect with the elderly residents who called the long-term care wing their temporary home. At 45, Margaret was known throughout the hospital for her meticulous attention to detail and her fierce advocacy for her patients. She had a reputation for noticing things that others missed, and for following through on concerns that other staff members might dismiss as minor. Her colleagues respected her instincts, and the doctors on her ward had learned to take her observations seriously. The geriatric ward at Riverside General housed 42 patients in private and semi-private rooms along two main corridors. Most were elderly individuals recovering from surgeries, managing chronic conditions, or transitioning between independent living and long-term care facilities. Many had family members who visited regularly, but there was also a significant population of patients who had few visitors and limited social support systems. It was this latter group that had been drawing Margaret's attention over the past several weeks. Beginning in early March 2023, she had started noticing a pattern of unusual incidents involving the hospital's most isolated elderly patients. At first, the incidents seemed minor and unrelated: personal items going missing, patients found in the wrong rooms, complaints about strangers entering their rooms at night. The first incident that caught Margaret's attention involved Mrs. Dorothy Walsh, an 82-year-old woman recovering from hip replacement surgery. Mrs. Walsh had been at Riverside for 3 weeks and was known to be a quiet, pleasant patient who rarely complained about anything. She had no immediate family and received visitors only from her church congregation about once a week. On the night of March 8, Margaret found Mrs. Walsh sitting up in bed at 2:30 a.m., visibly distressed and clutching her blankets around her shoulders. "Mrs. Walsh, are you having trouble sleeping?" Margaret asked gently, entering the room and checking the patient's chart on her tablet. "He was here again," Mrs. Walsh whispered, her eyes darting toward the door. "The man who comes at night. He said I owe him money for keeping me safe." Margaret pulled up a chair beside the bed, her nursing instincts immediately alert. "What man, Mrs. Walsh? Can you describe him?" "Tall, dark hair. He wears scrubs like you do, but something about him isn't right." Mrs. Walsh's hands shook as she spoke. "He says if I don't pay him, bad things might happen to me. He knows I don't have family to check on me." Margaret made careful notes in her tablet, documenting Mrs. Walsh's statements in the time of the incident. She had worked in hospitals long enough to know that elderly patients sometimes experienced confusion or hallucinations, especially during overnight hours, but Mrs. Walsh showed no signs of dementia or medication-related confusion during the day, and her account was detailed and consistent. "Mrs. Walsh, did this person touch you or take anything from your room?" Margaret asked. "He looked through my purse," Mrs. Walsh replied. "Said he was checking to see how much I could afford to pay for protection. I only have about $40 with me." Margaret made additional notes and assured Mrs. Walsh that she would investigate the incident. She also made a point of checking on Mrs. Walsh every hour for the remainder of her shift, but no unusual activity occurred. The next morning, Margaret documented the incident in the hospital's electronic reporting system and flagged it for follow-up by the day shift supervisor. She also made a point of discussing Mrs. Walsh's account with the day nurse who would be caring for her. "Mrs. Walsh seemed fine during the day yesterday," the day nurse reported. "No signs of confusion or agitation. She's been a model patient." This discrepancy between Mrs. Walsh's nighttime distress and her daytime demeanor was the first red flag that made Margaret suspect something more serious might be occurring. 3 days later, Margaret encountered a similar situation with another patient, Mr. Eugene Foster, a 79-year-old man being treated for pneumonia. Mr. Foster had been at Riverside for 10 days, and like Mrs. Walsh, had limited family support and few visitors. At approximately 1:45 a.m. on March 12th, Margaret found Mr. Foster's room empty. His bed was unmade and his personal belongings were scattered, but there was no indication of where he might have gone. Margaret immediately began searching for him, checking common areas and asking the security guard if he had seen Mr. Foster. They found Mr. Foster in the stairwell, on the floor below the geriatric ward, sitting on the concrete steps in his hospital gown, and appearing disoriented. "Mr. Foster, what are you doing here?" Margaret asked, as she and the security guard helped him to his feet. "He told me to come down here," Mr. Foster said, his voice shaky. "Said if I didn't bring him money, he would push me down the stairs and make it look like an accident." The security guard, a young man named David Rodriguez, looked at Margaret with concern. "Did he say who told him this?" "A man in scrubs. He said he works here and knows which patients don't have family watching out for them." Mr. Foster's eyes filled with tears. He said, "No one would believe me if I told anyone." Margaret and David helped Mr. Foster back to his room, where Margaret conducted a thorough assessment to ensure he hadn't been injured. She then spent time talking with him about what had happened, documenting his account in detail. Mr. Foster's story was remarkably similar to Mrs. Walsh's. A man in medical scrubs had approached him during the night, claimed to be providing protection services, and demanded payment. The man had specifically mentioned that Mr. Foster had limited family support and suggested that no one would believe his story if he reported it. Margaret was now convinced that these incidents were not coincidences or the products of elderly confusion. Someone was systematically targeting vulnerable patients on her ward, using their isolation and the credibility challenges often faced by elderly individuals to avoid detection. Over the following 2 weeks, Margaret documented 4 additional similar incidents. Each involved elderly patients with limited family support. Each occurred during overnight hours, and each followed the same pattern. A man in medical scrubs approaching patients, claiming to provide protection services and demanding payment. The patients' descriptions of the perpetrator were consistent. A tall man with dark hair, probably in his 30s or early 40s, wearing medical scrubs and speaking with confidence and authority. He seemed to know personal details about each patient, including their family situations and financial circumstances. Margaret dutifully documented each incident in the hospital's electronic reporting system, providing detailed accounts of the patient's statements and her own observations. She also reported the pattern to her supervisor and requested that additional security measures be implemented during overnight hours. However, when Margaret checked the system a few days later to follow up on her reports, she made a disturbing discovery. Several of her incident reports had been deleted from the system, with no explanation or record of who had removed them. Margaret immediately contacted her supervisor, Janet Morrison, about the missing reports. "Are you sure you submitted them correctly?" Janet asked. "The system has been having some technical issues lately. Reports sometimes don't save properly." "I'm absolutely certain I submitted them," Margaret replied. "I have copies of all my notes, and I remember exactly when I entered each report." Janet promised to look into the technical issues, but when Margaret checked again the following week, she found that even more of her recent incident reports were missing from the system. Only reports about routine medical issues remained. Anything related to the suspicious nighttime incidents had been systematically removed. This discovery made Margaret realize that the problem was far more serious than random criminal activity. Someone with access to the hospital's computer system was actively working to cover up the incidents she was reporting. This suggested that the perpetrator either worked at the hospital or had an accomplice who did. Margaret decided that she needed to conduct her own investigation, independent of the hospital's official reporting system. She began keeping detailed handwritten notes about every suspicious incident, storing them in a locked drawer at home, rather than relying on the hospital's electronic system. She also began paying closer attention to the staff members who had access to her ward during overnight hours. This included security guards, cleaning staff, and any medical personnel who might have legitimate reasons to be in patient rooms during the night shift. Margaret's investigation took on new urgency when she discovered that some of the targeted patients were not just being threatened, they were actually paying the money being demanded. Mrs. Walsh, embarrassed to admit she had been intimidated, eventually confided to Margaret that she had given the mysterious man $20 from her purse. "I was so scared," Mrs. Walsh admitted. "He said if I paid him, he would make sure nothing bad happened to me, but if I told anyone or didn't pay, there might be accidents." Mr. Foster also eventually admitted that he had paid the man, giving him the $15 he had in his wallet. Both patients begged Margaret not to report their payments, fearing retaliation from their tormentor. Margaret realized that she was dealing with a systematic extortion scheme targeting the hospital's most vulnerable patients. The perpetrator was using the patients' isolation, their fear of not being believed, and their physical vulnerability to extract money from them. The scheme was particularly insidious because it exploited the power dynamic between healthcare workers and patients. The perpetrator wore medical scrubs and spoke with authority, leading patients to believe he was a legitimate hospital employee who had the power to affect their care. After documenting 8 separate incidents over the course of a month, Margaret decided that she needed to take more direct action to identify and stop the perpetrator. The hospital's administration had either failed to address her concerns or was actively covering up the incidents, so she would have to handle the investigation herself. Margaret began planning a surveillance operation that she would conduct on her own time. She arranged to stay at the hospital after her overnight shift ended at 7 a.m., positioning herself where she could observe the geriatric ward during the early morning hours when the day shift was taking over. Her plan was to identify any suspicious individuals who might be lingering in the area or observing which patients had limited family support. She also hoped to catch the perpetrator in the act if he was bold enough to operate during shift change times. On the morning of April 15th, Margaret positioned herself in a family waiting area that had a clear view of the main corridor of the geriatric ward. She had changed out of her scrubs and into civilian clothes, hoping to blend in as a visitor rather than hospital staff. At approximately 8:30 a.m., Margaret observed a man in medical scrubs walking slowly down the corridor, stopping to peer into patient rooms and seemingly taking note of which rooms had visitors and which did not. The man matched the description provided by her patients, tall, dark-haired, and appearing to be in his late 30s. Margaret watched as the man spent several minutes observing the activity around each room. When he reached Mrs. Walsh's room, he lingered longer than at other doors, apparently listening to conversations inside. Mrs. Walsh had mentioned that a church member was planning to visit her that morning, and Margaret could see that there was indeed a visitor in the room. The man moved on to Mr. Foster's room, and again spent time apparently assessing the situation. Mr. Foster had no scheduled visitors, and his room appeared quiet. Margaret discreetly took photographs of the man using her phone, being careful not to draw his attention. She also made detailed notes about his behavior and the time he spent observing each room. After about 20 minutes, the man left the ward and headed toward the elevator. Margaret waited a few minutes before following, hoping to see where he went within the hospital. She followed him to the basement level, where the hospital's administrative offices, storage areas, and employee facilities were located. The man walked confidently through the corridors, as if he belonged there, eventually entering an office marked Patient Services. Margaret noted the location but did not attempt to follow him into the office. Instead, she returned to the geriatric ward and began asking subtle questions of her colleagues about the Patient Services department and who worked there. She learned that Patient Services handled a variety of administrative functions, including patient billing, insurance coordination, and discharge planning. The staff in that department would have access to detailed patient records, including information about family contacts, insurance coverage, and financial situations. This information was highly significant because it explained how the perpetrator knew so much about the patients he was targeting. Someone with access to patient records would know which patients had limited family support, what their financial situations were, and when they were likely to be alone in their rooms. Margaret realized that she had identified not just the perpetrator, but also the method he was using to select his victims. Armed with this information, she decided it was time to contact law enforcement directly, rather than continuing to work through the hospital's administration. On April 16th, Margaret called the police department and reported the systematic extortion scheme targeting elderly patients at Riverside General Hospital. She provided detailed documentation of all the incidents she had witnessed, along with the photographs she had taken of the suspect. Detective Linda Rodriguez was assigned to investigate Margaret's complaint. Rodriguez was a veteran investigator with the department's Elder Abuse Unit and had extensive experience with crimes targeting senior citizens. "Miss Chen, you've provided very thorough documentation," Detective Rodriguez told Margaret during their initial meeting. "This appears to be a clear pattern of elder abuse and extortion. We'll need to coordinate with the hospital administration to investigate this properly." Margaret explained her concerns about the hospital's response to her previous reports and the mysterious deletion of her incident reports from the system. "That's definitely concerning," Rodriguez agreed. "It suggests that someone within the hospital administration may be involved or at least enabling this activity. We'll need to handle this investigation carefully to avoid alerting anyone who might be helping the perpetrator." Over the next week, Detective Rodriguez worked with Margaret to develop a plan for catching the perpetrator in the act. They decided that Margaret would continue her normal duties, but would immediately contact Rodriguez if she observed any suspicious activity. They also arranged for undercover officers to pose as visitors in the geriatric ward during overnight hours, hoping to observe the perpetrator's activities without alerting him to the investigation. The breakthrough came on the night of April 22nd. Margaret was making her routine rounds when she heard voices coming from Mr. Foster's room. She approached quietly and listened at the door, recognizing one voice as belonging to Miss Foster and the other as matching the description of the man she had observed earlier. "You need to understand that things happen to patients who don't cooperate," the unfamiliar voice was saying. "Falls, medication errors, problems with your care. But if you keep paying me, I make sure you're well taken care of." Margaret immediately activated a silent alarm system that connected directly to Detective Rodriguez. Within minutes, plainclothes officers were positioned around the geriatric ward. When the man emerged from Mr. Foster's room, he was confronted by Detective Rodriguez and two other officers. "Sir, we need to speak with you," Rodriguez said, showing her badge. "We're investigating reports of extortion targeting elderly patients." The man, who appeared startled but tried to maintain his composure, identified himself as Kevin Mitchell, a patient services coordinator at the hospital. "I don't know what you're talking about," Mitchell said. "I was just checking on a patient's discharge planning." "At 2:30 in the morning?" Rodriguez asked. "And why was the patient talking about paying you for protection?" Mitchell's confident demeanor began to crumble as the officers questioned him about his activities and his access to patient records. When they searched his possession, they found cash that he could not account for, as well as a notebook containing names and room numbers of elderly patients with limited family support. Under questioning, Mitchell eventually admitted to the extortion scheme. He revealed that he had been targeting vulnerable elderly patients for over 6 months, using his access to patient records to identify victims and his medical credentials to intimidate them into paying him. Mitchell had been systematic in his approach, focusing on patients who had limited family contact, significant medical needs, and some financial resources. He used his knowledge of hospital operations to threaten patients with accidents or medication errors if they didn't pay him for protection. The investigation revealed that Mitchell had victimized at least 23 elderly patients over the course of his scheme, extracting amounts ranging from $10 to several $100s from each victim. He had collected over $4,000 through his extortion activities. Even more disturbing, the investigation uncovered that Mitchell had not been working alone. He had been sharing information about potential victims with accomplices outside the hospital, including individuals who would target the same patients for additional scams after their discharge. The case expanded to include mail fraud, wire fraud, and conspiracy charges as investigators traced Mitchell's connections to a larger criminal network that specifically targeted elderly individuals in healthcare settings. Mitchell's arrest led to a comprehensive review of Riverside General Hospital's security protocols and administrative procedures. The investigation revealed that Mitchell had indeed been systematically deleting incident reports from the hospital's computer system, using his administrative access to cover up complaints about his activities. The hospital administration faced significant scrutiny for their failure to respond appropriately to Margaret's repeated reports. Several senior administrators were disciplined or terminated for their handling of the situation. Margaret was recognized by both the hospital and law enforcement for her persistent investigation and her advocacy for vulnerable patients. Her actions had not only stopped an ongoing criminal enterprise, but had also exposed systemic problems in the hospital's oversight and security procedures. The case had far-reaching implications beyond just Mitchell's prosecution. It highlighted the vulnerability of elderly patients in healthcare settings and the need for better protections against exploitation and abuse. Margaret testified at Mitchell's trial, providing detailed accounts of the incidents she had witnessed and documented. Her meticulous record-keeping and professional observations were crucial in securing Mitchell's conviction. Mitchell was ultimately sentenced to 5 years in prison and ordered to pay restitution to all of his victims. Several of his accomplices were also prosecuted and sentenced for their roles in the broader criminal scheme. The case led to changes in how hospitals handle incident reporting and elder abuse prevention. Riverside General implemented new protocols for investigating complaints about patient safety and established independent oversight mechanisms to prevent the suppression of incident reports. Margaret's experience became a model for other healthcare workers who suspected abuse or exploitation in their facilities. Her persistence in the face of administrative resistance demonstrated the importance of advocating for vulnerable patients even when doing so was difficult or met with opposition. 1 year after Mitchell's arrest, Margaret was promoted to a supervisory role in the hospital's Quality Assurance Department, where she was responsible for investigating patient complaints and ensuring that all incidents were properly documented and addressed. She also became involved in training programs for healthcare workers, teaching them how to recognize signs of elder abuse and how to advocate effectively for their patients. Her experience had shown that healthcare workers were often in unique positions to identify and prevent crimes against vulnerable patients. The elderly patients who had been victimized by Mitchell received not only financial restitution, but also counseling and support services to help them process their experiences. Many of them credited Margaret with saving them from ongoing exploitation and abuse. Mrs. Walsh, who had been one of Mitchell's first victims, wrote a letter to Margaret expressing her gratitude. "You were the only person who listened to me and believed me when I said something was wrong. Without you, he would have kept hurting people like me." Mr. Foster, who had also been targeted early in Mitchell's scheme, similarly thanked Margaret for her advocacy. "You showed me that there are still people who care about patients like me, even when we don't have family to speak up for us." The case had a profound impact on Margaret's career and her understanding of her role as a healthcare provider. She realized that advocating for patients sometimes meant challenging authority figures and institutional systems that failed to protect vulnerable individuals. Margaret's experience also highlighted the importance of trusting clinical instincts and pursuing concerns, even when they were initially dismissed or covered up. Her willingness to conduct her own investigation when official channels failed had been crucial in stopping Mitchell's crimes. 2 years after the case was resolved, Margaret was invited to speak at a national conference on elder abuse prevention. She shared her experience with hundreds of healthcare workers, law enforcement officers, and advocates, encouraging them to remain vigilant for signs of exploitation and abuse in their own facilities. During her presentation, Margaret emphasized several key lessons from her experience. First, healthcare workers should always take seriously any complaints from elderly patients about mistreatment or exploitation, even if the complaints seem unlikely or are dismissed by other staff members. Second, systematic documentation is crucial when investigating suspected abuse. Keeping detailed records outside of official systems can be important if there are concerns about internal cover-ups or suppression of reports. Third, healthcare workers have a professional and ethical obligation to advocate for their patients, even when doing so puts them in conflict with institutional authorities. Fourth, Elder abuse often targets the most vulnerable individuals, those with limited family support, cognitive impairments, or financial constraints. Healthcare workers should be especially vigilant about protecting these patients. Finally, Margaret stressed that individual healthcare workers could make a significant difference in preventing and stopping elder abuse, but that institutional support and proper protocols were essential for creating safe environments for vulnerable patients. The case also contributed to broader conversations about elder abuse prevention and the responsibilities of healthcare institutions to protect their patients. Legislative changes were proposed in several states to strengthen reporting requirements and oversight mechanisms for elder abuse in healthcare settings. 5 years after Mitchell's conviction, Margaret continued to work in quality assurance at Riverside General Hospital, where she had implemented numerous improvements to patient safety and incident reporting procedures. The hospital had not experienced any similar cases of systematic patient exploitation since Mitchell's arrest. Margaret often reflected on the case and the factors that had enabled her to uncover Mitchell's crimes. Her nursing experience and clinical instincts had been crucial, but equally important had been her willingness to persist in the face of institutional resistance and her commitment to advocating for patients who had no one else to speak for them. She also recognized that the case had been successful because she had eventually involved law enforcement and worked within the legal system to address the crimes she had uncovered. While healthcare workers had important roles in identifying and preventing elder abuse, ultimately it was the criminal justice system that had held Mitchell accountable and provided justice for his victims. Margaret's experience demonstrated that individual healthcare workers, armed with clinical expertise, careful documentation, and persistent advocacy, could play crucial roles in protecting vulnerable patients from exploitation and abuse. Her story continued to inspire other healthcare workers to remain vigilant and to speak up when they suspected that patients were being mistreated. The case of Kevin Mitchell and the systematic exploitation of elderly patients at Riverside General Hospital became a landmark example of how healthcare workers could identify and stop crimes against vulnerable populations. Margaret Chen's investigation and advocacy had not only stopped ongoing criminal activity but had also contributed to broader improvements in elder abuse prevention and patient protection. 10 years later, Margaret was recognized with a national award for her contributions to patient advocacy and elder abuse prevention. In her acceptance speech, she emphasized that her actions had been driven by a simple principle that she believed should guide all healthcare workers: the responsibility to speak up for patients who could not speak for themselves. Every elderly patient deserves to feel safe and protected in healthcare settings, Margaret said during her speech. When we see signs that someone is being exploited or abused, we have a professional and moral obligation to investigate and advocate for them, no matter what obstacles we might face. Margaret's story remained a powerful example of how individual healthcare workers, through careful observation, thorough documentation, and persistent advocacy, could make a critical difference in protecting vulnerable patients from harm. Her experience continued to be used in training programs and educational materials, inspiring new generations of healthcare workers to remain vigilant for signs of elder abuse and to never give up on advocating for their patients' safety and well-being. The investigation that began with Margaret noticing a pattern of suspicious incidents on her night shift had ultimately led to the protection of dozens of elderly patients, the prosecution of multiple criminals, and significant improvements in elder abuse prevention protocols throughout the healthcare industry. Her story proved that sometimes the most important work in healthcare happened not in dramatic medical emergencies, but in the quiet moments when skilled professionals noticed that something was wrong and refused to look away. But Margaret's story was far from over. In the years following Mitchell's conviction, she would discover that elder abuse in healthcare settings was more widespread and systematic than anyone had imagined. Her expertise in identifying and investigating such cases would make her a sought-after consultant and advocate, leading to discoveries that would shock the healthcare industry and result in sweeping reforms. 3 years after Mitchell's conviction, Margaret received a call that would thrust her back into the world of elder abuse investigation. Dr. Patricia Williams, the chief medical officer at Mercy General Hospital in a neighboring city, had heard about Margaret's work at Riverside and was seeking her consultation on a troubling situation at her facility. Miss Chen, we've been experiencing some concerning incidents in our long-term care unit, Dr. Williams explained during their phone conversation. Several elderly patients have reported missing personal items, and there have been complaints about staff members asking for money or gifts. Our administration has been handling it internally, but the incidents keep occurring. Margaret agreed to visit Mercy General and conduct an informal assessment of their situation. What she found there would reveal that Mitchell's case had been part of a much larger pattern of elder abuse that extended across multiple healthcare facilities in the region. During her 2-day observation at Mercy General, Margaret identified several red flags that were remarkably similar to what she had encountered at Riverside. Elderly patients with limited family support were reporting incidents of intimidation and extortion. Personal belongings were disappearing from rooms. Most concerning, several patients described being approached by staff members who demanded payment for extra care or protection. Margaret's interviews with staff members revealed a culture of looking the other way when elderly patients made complaints. Many nurses and administrators assumed that confused elderly patients were making up stories or misremembering interactions with staff members. "We get these complaints all the time," one supervisor told Margaret. "Elderly patients often think people are stealing from them or threatening them. We've learned not to take every story seriously, or we'd be investigating something every day." This dismissive attitude toward elderly patients' complaints was exactly what had allowed Mitchell to operate undetected for so long at Riverside. Margaret realized that this cultural problem was widespread in healthcare settings and was enabling systematic abuse of vulnerable patients. Margaret's investigation at Mercy General uncovered evidence of a complex scheme involving multiple staff members who were targeting elderly patients for financial exploitation. The scheme was more sophisticated than Mitchell's individual operation and involved nursing assistants, orderlies, and even some administrative staff who had access to patient records. The perpetrators at Mercy General had developed methods for identifying vulnerable patients, coordinating their approaches to avoid detection, and sharing information about which patients were most likely to pay money to avoid problems with their care. They had also developed techniques for making their demands seem like legitimate requests for gratuities or donations. Margaret documented extensive evidence of the abuse and worked with law enforcement to develop a comprehensive investigation. The case ultimately resulted in the arrest of 7 staff members and exposed institutional failures that had enabled the abuse to continue for over 2 years. The Mercy General case established Margaret as a leading expert in healthcare elder abuse investigation. She began receiving requests from hospitals, nursing homes, and assisted living facilities across the country to help them assess their vulnerability to elder abuse and develop prevention protocols. Margaret took a leave of absence from her position at Riverside General to focus full-time on this consulting work. She developed comprehensive assessment tools that healthcare facilities could use to evaluate their risk factors for elder abuse and identify potential warning signs. Her assessment protocol included reviews of incident reporting systems, staff hiring and training practices, patient complaint procedures, and institutional culture factors that might enable abuse. She also developed specialized training programs for healthcare workers to help them recognize and respond appropriately to signs of elder abuse. Over the following 2 years, Margaret consulted with more than 30 healthcare facilities across 15 states. Her work revealed that elder abuse in healthcare settings was far more common than previously understood. She documented cases of financial exploitation, physical abuse, emotional abuse, and neglect that had been occurring undetected in facilities with good reputations and proper accreditation. Margaret's findings were published in several medical journals and healthcare industry publications. Her research demonstrated that elderly patients in healthcare settings were particularly vulnerable to abuse because of their physical dependence, social isolation, cognitive vulnerabilities, and the power imbalances inherent in healthcare relationships. She identified several systemic factors that increased the risk of elder abuse in healthcare settings. First, inadequate background screening and supervision of staff members who had direct access to vulnerable patients. Many facilities relied on basic criminal background checks that might not identify individuals with histories of financial crimes or elder abuse. Second, institutional cultures that dismissed or minimized complaints from elderly patients. When staff members assumed that elderly patients were confused or unreliable, it created opportunities for abusive individuals to operate without detection. Third, inadequate documentation and reporting systems that failed to identify patterns of suspicious incidents. Many facilities lacked systems for tracking complaints across multiple patients or identifying staff members who were associated with multiple incidents. Fourth, insufficient training for healthcare workers about recognizing and responding to elder abuse. Many healthcare professionals had received minimal education about elder abuse during their training and were not equipped to identify subtle signs of exploitation or intimidation. Fifth, lack of independent oversight and advocacy for elderly patients. Many patients in healthcare settings had limited contact with family members or advocates who might notice changes in their behavior or circumstances that could indicate abuse. Margaret's research and consulting work attracted the attention of federal agencies responsible for healthcare regulation and elder abuse prevention. She was invited to serve on a national task force developing new guidelines for elder abuse prevention in healthcare settings. The task force's work resulted in new federal regulations requiring healthcare facilities to implement comprehensive elder abuse prevention protocols. These regulations mandated improved staff training, enhanced incident reporting systems, and regular assessments of institutional risk factors for elder abuse. Margaret also became involved in training law enforcement officers and prosecutors about elder abuse in healthcare settings. Her experience had shown that many criminal justice professionals were not familiar with the unique characteristics of these crimes and needed specialized training to investigate and prosecute them effectively. She developed training materials and conducted workshops for law enforcement agencies across the country, teaching investigators how to recognize signs of systematic elder abuse and how to build strong cases against perpetrators who exploited their positions in healthcare settings. Margaret's work also led to improvements in how healthcare facilities screened and supervised employees who worked with vulnerable patients. She developed recommendations for enhanced background checks, reference verification procedures, and ongoing monitoring of staff members who had access to elderly patients. 5 years after Mitchell's conviction, Margaret established the Center for Healthcare Elder Abuse Prevention, a non-profit organization dedicated to research, training, and advocacy related to elder abuse in healthcare settings. The center received funding from foundations, government agencies, and healthcare organizations to support its mission. The center's research program conducted studies on the prevalence and characteristics of elder abuse in different types of healthcare settings. Margaret's team published findings showing that elder abuse occurred in hospitals, nursing homes, assisted living facilities, and home healthcare settings, with varying patterns and risk factors in each environment. The center also developed and implemented training programs for healthcare workers, administrators, and regulators. These programs were designed to increase awareness of elder abuse, improve prevention practices, and enhance response procedures when abuse was suspected or identified. Margaret's advocacy work through the center led to legislative changes in several states that strengthened protections for elderly patients in healthcare settings. These laws included enhanced penalties for elder abuse by healthcare workers, improved reporting requirements, and mandatory training programs for healthcare professionals. The center also provided direct support to elderly victims of healthcare abuse and their families. Margaret's team helped victims access legal services, counseling support, and other resources needed to recover from their experiences and seek justice against perpetrators. One of the center's most significant achievements was the development of a national database for tracking elder abuse incidents in healthcare settings. This database allowed researchers and policymakers to identify patterns and trends in elder abuse cases and develop more effective prevention strategies. The database revealed that elder abuse in healthcare settings was occurring in all types of facilities and all geographic regions, but that certain factors significantly increased the risk. 8 years after Mitchell's arrest, Margaret was appointed to serve on a congressional committee investigating elder abuse in healthcare settings. Her testimony before Congress highlighted the widespread nature of the problem and the need for comprehensive federal action to protect vulnerable elderly patients. Elder abuse in healthcare settings is not limited to a few bad employees or poorly managed facilities, Margaret told the congressional committee. It is a systemic problem that requires systematic solutions. We need stronger oversight, better training, enhanced accountability, and a fundamental change in how we view and protect the rights of elderly patients. Margaret's congressional testimony contributed to the passage of comprehensive federal legislation addressing elder abuse in healthcare settings. The Elder Patient Protection Act established new federal standards for elder abuse prevention, created funding for training and research programs, and enhanced penalties for healthcare workers who exploited elderly patients. The legislation also created a federal task force on healthcare elder abuse, with Margaret serving as its first chairperson. The task force was responsible for coordinating federal efforts to prevent elder abuse, supporting research and training initiatives, and developing national standards for healthcare facilities. Under Margaret's leadership, the task force launched a comprehensive national campaign to raise awareness about elder abuse in healthcare settings. The campaign included public service announcements, educational materials for patients and families, and resources for healthcare workers and administrators. The task force also established a national hotline for reporting suspected elder abuse in healthcare settings. The hotline was staffed by trained professionals who could provide immediate assistance to victims and connect them with appropriate resources and law enforcement agencies. 10 years after her initial investigation at Riverside General, Margaret had become one of the nation's most recognized experts on elder abuse prevention. She had consulted with hundreds of healthcare facilities, trained thousands of healthcare workers, and helped develop policies and procedures that had prevented countless cases of elder abuse. The impact of Margaret's work extended far beyond the individual cases she had investigated. Her research and advocacy had contributed to a fundamental shift in how the healthcare industry approached elder abuse prevention. Healthcare facilities were now required to implement comprehensive prevention protocols, and healthcare workers received mandatory training about recognizing and reporting elder abuse. Margaret often reflected on the case that had started her involvement in elder abuse prevention. Mitchell's systematic exploitation of vulnerable patients at Riverside General had been horrific, but it had also revealed the broader problem of elder abuse in healthcare settings and provided the catalyst for comprehensive reforms. She sometimes wondered how many other cases like Mitchell's were occurring undetected in healthcare facilities across the country. Her work had shown that elder abuse was far more common than most people realized, and that many cases were never reported or investigated. But Margaret was also encouraged by the progress that had been made. Healthcare facilities were now much more aware of their responsibilities to protect elderly patients, and there were better systems in place for preventing, detecting, and responding to elder abuse. Margaret's story had become a model for healthcare workers who suspected abuse or neglect in their facilities. Her persistence in the face of institutional resistance, her meticulous documentation of suspicious incidents, and her willingness to work with law enforcement had shown that individual healthcare workers could make a significant difference in protecting vulnerable patients. 12 years after Mitchell's conviction, Margaret was honored with a Lifetime Achievement Award from the American Nurses Association for her contributions to patient advocacy and elder abuse prevention. In her acceptance speech, she emphasized that her work had been motivated by a simple principle that she believed should guide all healthcare professionals. Every elderly patient deserves to feel safe and respected in healthcare settings, Margaret said. When we see signs that someone is being exploited or abused, we have both a professional and moral obligation to investigate and advocate for them. We cannot allow institutional pressures or administrative convenience to override our responsibility to protect the most vulnerable patients in our care. Margaret continued her work through the Center for Healthcare Elder Abuse Prevention, which had grown into a major research and advocacy organization with offices in multiple states. The center's work was now supported by federal funding and had become a recognized leader in elder abuse prevention research and training. The center's research continued to reveal new aspects of elder abuse in healthcare settings and to develop innovative prevention strategies. Margaret's team had identified emerging trends in elder abuse, including the use of technology to exploit elderly patients and the targeting of patients with dementia and other cognitive impairments. The center also worked with healthcare technology companies to develop systems that could help detect and prevent elder abuse. These systems used artificial intelligence and data analysis to identify patterns of suspicious activity that might indicate abuse or exploitation. 15 years after the Mitchell case, Margaret published a comprehensive book about her experiences investigating and preventing elder abuse in healthcare settings. Silent Victims: Protecting Elderly Patients from Healthcare Abuse became a standard reference for healthcare professionals, law enforcement officers, and policymakers working on elder abuse issues. The book detailed Margaret's investigation of the Mitchell case, her subsequent consulting work, and the broader systemic changes that had resulted from her advocacy. It also provided practical guidance for healthcare workers who suspected abuse in their facilities and for families who wanted to protect elderly relatives in healthcare settings. Margaret's book included case studies from many of the investigations she had conducted over the years, illustrating the various forms that elder abuse could take in healthcare settings. These cases showed that elder abuse was not limited to financial exploitation, but could include physical abuse, emotional abuse, neglect, and violations of patients' rights and dignity. The book also addressed the institutional and cultural factors that enabled elder abuse in healthcare settings. Margaret argued that preventing elder abuse required not just better policies and procedures, but fundamental changes in how healthcare organizations viewed and treated elderly patients. Margaret emphasized that elderly patients were often seen as burdens rather than valued individuals with rights and dignity. This attitude created an environment where abuse and neglect could flourish, because elderly patients were not viewed as deserving of the same respect and protection as other patients. In her book, Margaret called for a comprehensive approach to elder abuse prevention that addressed individual, institutional, and societal factors. She argued that protecting elderly patients required not just better training and oversight, but also changes in societal attitudes toward aging and the value of elderly individuals. Margaret's book was widely praised by reviewers and became required reading in many nursing schools and healthcare administration programs. It helped educate a new generation of healthcare professionals about the importance of elder abuse prevention and the role that individual healthcare workers could play in protecting vulnerable patients. 20 years after her initial investigation at Riverside General, Margaret continued to work as a consultant and advocate. Though she had reduced her travel schedule and focused more on writing and research, she remained actively involved with the Center for Healthcare Elder Abuse Prevention, which continued to grow and expand its impact. Margaret often spoke to nursing students and young healthcare professionals about her experiences and the lessons she had learned from her work in elder abuse prevention. She encouraged them to trust their instincts when they suspected that something was wrong and to persist in their advocacy even when they faced resistance from institutional authorities. Your patients are depending on you to notice when something isn't right and to speak up for them when they cannot speak for themselves. Margaret would tell nursing students, that responsibility doesn't end when your shift ends or when administrators tell you not to worry about something. It's a fundamental part of being a healthcare professional. Margaret's legacy extended far beyond the individual cases she had investigated or the policies she had helped develop. Her work had contributed to a fundamental change in how the healthcare industry approached elder abuse prevention and had inspired countless healthcare workers to become better advocates for their patients. The systematic changes that had resulted from Margaret's work had undoubtedly prevented thousands of cases of elder abuse and protected countless vulnerable elderly patients from exploitation and harm. Healthcare facilities across the country now had better policies, procedures, and training programs in place to prevent elder abuse. But perhaps Margaret's most important contribution was demonstrating that individual healthcare workers, armed with professional expertise, careful observation, and persistent advocacy, could make a profound difference in protecting vulnerable patients. Her story showed that one person's willingness to notice patterns, document concerns, and refuse to be silenced could ultimately lead to systemic changes that protected thousands of people. As Margaret looked back on her career, she was proud of the impact her work had made, but also aware that elder abuse remained a significant problem in healthcare settings. New forms of abuse were constantly emerging, and healthcare facilities continued to face challenges in recruiting, training, and supervising staff members who worked with vulnerable patients. Margaret knew that the fight against elder abuse in healthcare settings would require ongoing vigilance and continuous improvement in prevention efforts, but she was optimistic that the systems and practices that had been developed as a result of her work would continue to protect elderly patients and that future generations of healthcare workers would carry on the mission of advocacy and protection. The case that had begun with Margaret noticing suspicious incidents during her night shift at Riverside General had ultimately transformed how the healthcare industry approached elder abuse prevention. Her investigation of Kevin Mitchell's crimes had been just the beginning of a career dedicated to protecting vulnerable elderly patients and ensuring that healthcare settings were safe environments for the most vulnerable members of society. Margaret's story remained an inspiration to healthcare workers, law enforcement officers, and advocates who were working to prevent elder abuse and protect vulnerable patients. Her example showed that individual professionals, through careful observation, thorough documentation, and persistent advocacy, could identify and stop systematic abuse and create lasting changes that protected countless others. The investigation that had started with a nurse noticing that something wasn't right during her night shift had evolved into a national movement for elder abuse prevention and a comprehensive system of protections for vulnerable elderly patients. Margaret Chen's legacy was measured not just in the individual cases she had solved, but in the thousands of elderly patients who were safer because of the systems and practices that had been developed as a result of her work. As Margaret entered her 70s, she continued to work part-time through the Center for Healthcare Elder Abuse Prevention, though she had transitioned from direct consulting to mentoring the next generation of investigators and advocates. Her experience and expertise remained invaluable to the organization she had founded, and she took particular pleasure in training young nurses and social workers who were passionate about protecting vulnerable patients. One of Margaret's protégés was Dr. Sarah Kim, a geriatric psychiatrist who had joined the center after completing her residency. Sarah had been inspired by Margaret's work and wanted to focus specifically on the psychological aspects of elder abuse in healthcare settings. Margaret taught me that elder abuse isn't just about financial exploitation or physical harm, Sarah often said when describing her mentor's influence. It's about the systematic erosion of dignity, autonomy, and humanity that can occur when vulnerable people are treated as objects rather than individuals with rights and feelings. Sarah's research, supported by Margaret's mentorship, revealed new insights into the long-term psychological effects of elder abuse in healthcare settings. Her studies showed that elderly patients who experienced abuse often developed severe depression, anxiety, and post-traumatic stress symptoms that could persist long after the abuse had ended. More importantly, Sarah's research demonstrated that elderly patients who experienced abuse in healthcare settings often lost trust in medical care entirely, leading them to avoid necessary treatment and resulting in worse health outcomes. This finding provided additional evidence for the importance of preventing elder abuse, not just as a matter of justice, but as a critical component of providing effective health care to elderly patients. Margaret also worked closely with Dr. James Patterson, a criminologist who studied the characteristics and motivations of healthcare workers who abused elderly patients. Patterson's research, conducted in collaboration with the center, provided important insights into the psychology of elder abuse perpetrators and helped develop better screening methods for identifying potentially abusive employees. Margaret's work showed us that elder abuse in healthcare settings isn't random, Patterson explained. It's often systematic and calculated, carried out by individuals who specifically target vulnerable patients. Understanding the psychology and methods of these perpetrators is crucial for preventing their crimes. Patterson's research identified several common characteristics among healthcare workers who abused elderly patients. These individuals often had histories of financial problems, substance abuse, or other personal difficulties that made them more likely to exploit vulnerable patients for financial gain. They also tended to be skilled manipulators who were able to gain the trust of patients and colleagues while hiding their abusive behavior. The research also revealed that many elder abuse perpetrators were repeat offenders who moved from facility to facility, leaving behind patterns of abuse that were often not detected because information was not shared between employers. This finding led to the development of better background checking systems and information sharing protocols for healthcare facilities. Margaret's influence extended beyond direct mentorship to the development of innovative training programs and educational materials. She worked with filmmakers to create documentary films about elder abuse cases, including a detailed account of her investigation of Kevin Mitchell that became widely used in training programs for healthcare workers and law enforcement officers. The documentary, titled Silent Victims: The Margaret Chen Story, was praised for its sensitive portrayal of elder abuse issues and its emphasis on the importance of professional advocacy and persistence in protecting vulnerable patients. The film won several awards and was translated into multiple languages for international distribution. Margaret also collaborated with technology companies to develop innovative tools for preventing and detecting elder abuse in healthcare settings. One of her most significant contributions was the development of an artificial intelligence system that could analyze patient records, incident reports, and staff scheduling data to identify patterns that might indicate systematic abuse. The AI system, known as the Elder Protection Alert Network, EPAN, was designed to detect subtle patterns that human reviewers might miss. The system could identify correlations between specific staff members and increased rates of patient complaints, unexplained injuries, or missing personal items. It could also flag situations where vulnerable patients were being assigned to the same staff members repeatedly, which was often a sign of targeting by abusive employees. EPAN was initially pilot-tested in 50 healthcare facilities across 10 states. The results were remarkable. The system identified potential abuse situations in 78% of facilities within the first 6 months of implementation. More importantly, facilities that used EPAN experienced a 65% reduction in confirmed elder abuse incidents over a 2-year period. The success of EPAN led to its adoption by hundreds of healthcare facilities nationwide, and eventually by healthcare systems in several other countries. Margaret's vision of using technology to protect vulnerable patients had become a reality that was saving countless elderly individuals from abuse and exploitation. Margaret also remained actively involved in policy advocacy and legislative development throughout her later career. She testified before state legislatures and federal agencies about the need for stronger protections for elderly patients and better funding for elder abuse prevention programs. One of her most significant legislative achievements was her contribution to the development of the National Elder Abuse Prevention and Response Act, which created a comprehensive federal framework for addressing elder abuse in all settings, including healthcare facilities. The legislation provided funding for research, training, and prevention programs, and established national standards for elder abuse prevention and response. Margaret's testimony before Congress was particularly powerful because she was able to draw on decades of experience and hundreds of cases to illustrate the scope and severity of elder abuse in healthcare settings. Her personal stories about individual patients who had been victimized brought a human dimension to the statistical data and policy discussions. Every elderly patient who experiences abuse in a healthcare setting is someone's parent, grandparent, or loved one. Margaret told Congress during one hearing, "They trusted us to care for them in their most vulnerable moments, and we failed them. We have a moral obligation to do better, and that requires not just good intentions, but systematic changes in how we prevent, detect, and respond to elder abuse." Margaret's advocacy work also focused on improving support services for elderly abuse survivors. She recognized that many elderly individuals who experienced abuse in healthcare settings needed specialized services to help them recover from their trauma and regain trust in medical care. Working with mental health professionals and victim advocates, Margaret helped develop specialized counseling programs for elderly abuse survivors. These programs were designed to address the unique needs of older adults who had experienced abuse in healthcare settings, including their fears about seeking medical care and their concerns about not being believed by family members or other healthcare providers. The counseling programs also addressed practical issues that elderly abuse survivors often faced, such as financial exploitation, legal problems, and the need for advocacy in dealing with healthcare systems and insurance companies. Margaret understood that comprehensive support required addressing not just the emotional trauma of abuse but also its practical consequences. Margaret's work with abuse survivors led to the development of victim advocacy programs, specifically designed for elderly individuals who had experienced abuse in healthcare settings. These programs provided trained advocates who could accompany elderly patients to medical appointments, help them navigate the healthcare system, and ensure that their rights and dignity were respected. The advocacy programs were particularly important for elderly patients who had lost trust in healthcare systems as a result of their abuse experiences. Having a trained advocate who understood their trauma and could help them communicate with healthcare providers was often crucial for getting these patients to seek necessary medical care. Margaret also recognized the importance of involving family members and caregivers in elder abuse prevention efforts. She developed educational programs for families that taught them how to recognize signs of abuse, how to advocate effectively for elderly relatives, and how to work with healthcare facilities to ensure proper care. These family education programs addressed common misconceptions about elder abuse and helped family members understand that abuse in healthcare settings was not limited to obviously negligent or poorly managed facilities. Margaret's research had shown that elder abuse could occur in well-regarded facilities with good reputations, making family vigilance important regardless of the quality of the facility. The programs also taught family members how to be effective advocates without being disruptive or adversarial. Margaret understood that healthcare facilities were more likely to cooperate with families who approached concerns in a constructive manner, and she helped families develop communication skills that would enable them to protect their elderly relatives while maintaining positive relationships with healthcare providers. 25 years after her initial investigation of Kevin Mitchell, Margaret was honored with the creation of the Margaret Chen Institute for Elder Protection at her alma mater's nursing school. The institute was established with funding from foundations, government grants, and donations from individuals who had been inspired by Margaret's work. The institute's mission was to continue Margaret's legacy by training future generations of healthcare workers in elder abuse prevention, and by conducting research on innovative approaches to protecting vulnerable patients. The institute offered specialized courses for nursing students, continuing education programs for practicing healthcare workers, and advanced training for professionals who wanted to specialize in elder protection work. Margaret served as the institute's first director and was actively involved in developing its curriculum and research programs. She was particularly proud of the institute's emphasis on practical, hands-on training that prepared healthcare workers to recognize and respond appropriately to signs of elder abuse in real-world settings. The institute also maintained the national database on elder abuse in healthcare settings that Margaret had helped establish years earlier. The database had grown to include information from thousands of healthcare facilities and had become an invaluable resource for researchers, policymakers, and facility administrators working to prevent elder abuse. Margaret's influence on the nursing profession extended beyond elder abuse prevention to broader issues of patient advocacy and professional ethics. She was frequently invited to speak at nursing conferences and schools about the importance of advocacy as a fundamental nursing responsibility. Nursing is not just about providing medical care, Margaret would tell nursing students. It's about serving as an advocate and protector for patients who are often vulnerable and unable to advocate for themselves. This is especially true for elderly patients who may face additional barriers to having their voices heard and their rights respected. Margaret's emphasis on advocacy and ethics influenced nursing education curricula across the country. Many nursing schools incorporated case studies based on her work into their ethics courses, and some schools established specialized tracks in elder care and abuse prevention inspired by her example. Margaret also mentored numerous doctoral students who conducted research related to elder abuse prevention and patient advocacy. Many of these students went on to become leaders in their own right, carrying forward Margaret's legacy of protecting vulnerable patients and improving healthcare systems. Dr. Maria Santos, one of Margaret's former doctoral students, became the director of elder services at a major medical center and implemented comprehensive elder abuse prevention protocols based on Margaret's research and recommendations. Under Santos's leadership, the medical center became a model for other facilities and experienced 0 confirmed cases of elder abuse over a 5-year period. Another former student, Dr. Robert Chen, no relation to Margaret, became a leading researcher in the field of healthcare ethics and developed innovative approaches to training healthcare workers about their ethical responsibilities to vulnerable patients. His work built directly on Margaret's research and extended it to address emerging challenges in healthcare delivery. As Margaret entered her 80s, she remained intellectually sharp and passionate about her work, though she had reduced her travel schedule and focused more on writing and mentoring. She published a second book, The The Evolution of Elder Protection, Lessons from 4 Decades in Healthcare, which reflected on the changes she had witnessed in healthcare and the ongoing challenges in protecting vulnerable patients. The second book was more philosophical and reflective than her first, drawing on Margaret's decades of experience to explore broader questions about aging, vulnerability, and society's responsibility to protect its most fragile members. The book was praised for its wisdom and insight, and became popular among healthcare professionals, policymakers, and general readers interested in aging issues. Margaret also began working on a third book, which she intended to be her final major work. This book, tentatively titled The Future of Elder Care, Building Systems That Honor Dignity and Humanity, was designed to provide a roadmap for the future of elder care, based on the lessons learned from decades of abuse prevention work. The third book addressed emerging challenges in elder care, including the growing aging population, changing family structures, advances in medical technology, and the need for new models of care that prioritize dignity and autonomy alongside medical treatment. Margaret drew on her extensive experience to provide practical recommendations for healthcare systems, policymakers, and families facing these challenges. Margaret's vision for the future of elder care emphasized the importance of person-centered approaches that recognize the individuality and humanity of each elderly person. She argued that preventing elder abuse required not just better policies and procedures, but fundamental changes in how society viewed and valued elderly individuals. Margaret's work on her third book was interrupted by health challenges that required her to reduce her activities and focus on her own care. However, she continued to work with her colleagues at the Center and the Institute to ensure that her vision and values would continue to guide their work even after she was no longer able to be actively involved. The Center for Healthcare Elder Abuse Prevention had grown into a major organization with an annual budget of over $10 million and staff members in 15 states. The organization continued to conduct research, provide training, and advocate for policy changes based on the foundation that Margaret had established. The Margaret Chen Institute for Elder Protection had also flourished, graduating hundreds of healthcare workers with specialized training in elder abuse prevention and conducting groundbreaking research on innovative protection strategies. The Institute's graduates had gone on to work in healthcare facilities, government agencies, and advocacy organizations across the country and around the world. Margaret's influence could be seen in the thousands of healthcare facilities that had implemented elder abuse prevention protocols based on her research and recommendations. These facilities had experienced dramatic reductions in elder abuse incidents and had created safer, more respectful environments for elderly patients. Her influence was also evident in the hundreds of laws and policies that had been enacted to strengthen elder protection. Federal and state legislation inspired by her work had created new protections for elderly patients, enhanced penalties for elder abuse perpetrators, and provided funding for prevention and response programs. Perhaps most importantly, Margaret's influence could be seen in the changed attitudes and increased awareness about elder abuse in healthcare settings. Healthcare workers who had been trained using her materials, policymakers who had been influenced by her advocacy, and family members who had learned from her educational programs were all part of a broad movement to protect elderly individuals from abuse and exploitation. Margaret often reflected on the case that had started her involvement in elder abuse prevention: Kevin Mitchell's systematic exploitation of vulnerable patients at Riverside General Hospital. That single investigation had revealed a problem that was far more widespread and serious than anyone had imagined, and it had catalyzed changes that had protected countless elderly individuals from similar abuse. She sometimes wondered about the elderly patients who had been helped by the systems and programs that had been developed as a result of her work. How many vulnerable individuals had been protected from abuse because healthcare workers had been trained to recognize warning signs? How many potential perpetrators had been deterred by improved screening and oversight procedures? How many elderly patients had received better care because of changed attitudes about their dignity and rights? While Margaret could never know the exact number of people who had been helped by her work, she was confident that the impact had been substantial. The systematic changes that had resulted from her efforts had created a safer environment for elderly patients throughout the healthcare system and had established principles and practices that would continue to protect vulnerable individuals for generations to come. As Margaret entered the final phase of her career, she was gratified to see that the work she had started with her investigation of Kevin Mitchell had grown into a comprehensive movement for elder protection that extended far beyond healthcare settings. The principles and practices she had developed were being applied to nursing homes, assisted living facilities, home care services, and other settings where elderly individuals were vulnerable to abuse and exploitation. Margaret's story had become more than just an account of one nurse's investigation of suspected abuse. It had become a testament to the power of individual professionals to identify and address systematic problems, and a demonstration of how persistence, courage, and expertise could lead to changes that protected thousands of vulnerable individuals. The investigation that had begun with Margaret noticing suspicious patterns during her night shift at Riverside General Hospital had evolved into a legacy of protection, advocacy, and reform that would continue to benefit elderly patients for decades to come. Her work had shown that sometimes the most important contributions to human welfare began with someone simply paying attention to things that didn't seem right and refusing to look away when vulnerable people needed help. Margaret Chen's legacy was not just in the policies, programs, and systems that bore her name, but in the fundamental shift in consciousness that her work had helped bring about. A recognition that protecting elderly individuals from abuse and exploitation was not just a professional responsibility for healthcare workers, but a moral obligation for society as a whole. Her story continued to inspire new generations of healthcare workers, advocates, and policymakers to carry forward the mission of creating a world where elderly individuals could age with dignity, safety, and respect.